This evening, joining me will be our three national experts. We'll first be starting with Dr. Joel Gelfand. Dr. Gelfand is Professor of Dermatology and Epidemiology, Vice Chair of Clinical Research, Medical Director of the Dermatology Clinical Studies Unit, as well as the Director of the Psoriasis and Phototherapy Treatment Center at the University of Pennsylvania Perelman School of Medicine in Philly. Dr. Gelfand, welcome. Thanks for being here this evening. Dr. Gelfand will be speaking to us this evening about the impact of the pandemic as it affects our patients with immune-mediated skin diseases, biologic and immunosuppressive therapies. So with that, Joel, if you'll go ahead and take over, and we'll look forward to your presentation.
Sure, Brad. Well, thank you for having me here tonight. It's a real pleasure to be able to work with you and Adam and Lauren. And I'm looking forward to hearing everyone's talks, and most important, looking forward to the questions we get from our colleagues around the country who are listening in. So, I thought I would start off with a little bit of perspective and a couple of quotes that sort of help guide me as we think about this time together. The first one is from Michael Levitt, who was a former Health and Human Services Department. And he said that everything we do before a pandemic will seem alarmist. Everything we do after a pandemic will seem inadequate. This is a dilemma we face, but should not stop us from doing what we can to prepare. We need to reach out to everyone with words that inform, but not inflame. We need to encourage everyone to prepare, but not panic. And I think for those of us as physicians, we're often leaders in our families, in our communities, certainly in our practices. And I think this is the type of equanimity we want to make sure we try to strike as we're sort of trying to cope with the changing information that's going on as we improve our knowledge of what's happening with COVID-19. The second quote is by Sir Austin Bradford Hill. He is known for his work identifying smoking as a risk factor for lung cancer, probably one of the most important epidemiological findings of the 20th century. And so he said that all scientific work is incomplete, whether it be observational or experimental. All scientific work is liable to be upset or modified by advancing knowledge that does not confer upon us the freedom to ignore knowledge we already have or to postpone the action that appears to demand at a given time. And that's what we as clinicians really have to master. This concept of uncertainty, what things we really know for certain from well-done randomized placebo-controlled trials, the things that may be more anecdotal, and how do we sort of convey that information to our patients or our staff, and how do we then make decisions in that environment. So I want to talk a little about psoriasis and SARS-CoV-2. That's the virus that causes COVID-19 illness. And psoriasis, first of all, we know is associated with a number of cardiovascular comorbidities, COPD, and diabetes, culminating in about a 5-year reduction in life expectancy. And because of these comorbidities that people with psoriasis often suffer from, these are some of the same ones that drive poor outcomes in people with COVID-19 illness. So lung disease, cardiovascular disease, diabetes are some of the things that really differentiate those who have bad outcomes from those who tend to have better outcomes. And so right off the bat, we know our patients with psoriasis are probably more prone to issues related to this disease. In this work that we did several years back, we found that infection was the second leading cause of mortality in people with moderate severe psoriasis, second only to cardiovascular disease. And that's been shown by a number of other investigators around the world. So we don't really know why people with psoriasis seem to have higher rates of mortality from infections. We don't really know if it's a treatment effect or something related to disease or their comorbidities, but at least gives us that perspective that this is an at-risk patient population. And then finally, most of our treatments for psoriasis, even the ones that are quite specific, still are immunosuppressive. They essentially work by interrupting cytokine networks that are important for immunity in the skin, as well as in other barrier tissues like the lung and the GI tract. And as a result, because of the uncertainty we have, we just don't know for certain that the effects our therapies would have on people with COVID-19 infection. The recommendations from AAD really center on shared decision-making, recommending stopping immune suppressive treatment in people with psoriasis who have symptoms of or test positive for COVID-19. And so this is pretty much how we've been counseling our patients for the last 6 to 7 weeks or so. where basically we think of it as sort of a tiered analysis. At a high level, patients who have a fairly mild underlying indication for their systemic agent, who may have major risk factors for bad outcomes from COVID-19, maybe they're older than 65, they have lung disease or diabetes. Those are people, if they're doing really well on their biologic, they may want to consider postponing the next shot and not restarting it until they see their psoriasis recurring. Because some patients will have a remission on the therapy they're on. On the other hand, a patient with very severe underlying disease who has a better prognostic profile, they may be younger or don't have major comorbidities. These are people who we feel probably safely can stay on these therapies during this time. But still, we feel on the safe side it's best to probably stop the therapies if they were to develop symptoms of infection or develop COVID-19 itself. Now, this is a nice paper.
What has been your posturing so far? Sorry. How have you been handling this?
Yeah, so it's very much a case-by-case basis. And I think this schema that came out in Dermatology Therapeutics by a group from UCSF, Wilson Liao is a senior author on it, sort of is a clinical guidepost for how clinicians can think about these issues. And so for me, I found that a lot of our communication goes through EMR, electronic medical record, correspondence back and forth, as well as we're doing a lot of telemedicine and counseling in that manner. And I essentially counsel my patients the same way I just sort of broke it down for our colleagues here. And I would say that probably most of my patients elect to want to stay on their therapies. A handful of patients, even younger people who are perfectly healthy and have very low risk, their disease is totally cleared, I say, you know what, I'd rather just wait for my next shot because there's a lot of uncertainty. And I think that's really the advantage of managing moderate severe psoriasis at this time in history where we have so many different treatment options for our patients, whether it be systemic biologics, oral medications, or ultraviolet phototherapy. We have a variety of ways to offer to manage the disease for our patients, and shared decision-making makes a lot of sense in that context.
Staying on biologic therapies, some of the older agents, the TNF inhibitors, and we have more targeted therapies in interleukin 17 and 23 blockers. Do you have a little bit more angst with the older biologic therapies, or you feel pretty much the same about all of them?
Yes, so there's different opinions out there, and that's exactly what they are, which is opinions, often informed by basic science models, mouse models that seem to suggest what these various cytokines do in viral defense, for example. The cytokines that we tend to be targeting in psoriasis aren't dominant players in viral immunity when it comes down to it. That being said, what we know from mouse models often doesn't apply to humans. So, for example, TNF inhibitors were first studied for sepsis, congestive heart failure, and multiple sclerosis. And we know that they make all those problems worse despite all the excellent basic science data at the time. And so you just don't know until the studies are done in humans. I think, today the data that's sort of been emerging is largely sort of reassuring. There's been no major safety signals so far. There was one report out of Italy, roughly 1,000 patients on systemic agents in their practice, and they weren't able to identify any of them who got admitted to the hospital with COVID illness. There's another paper that recently came out in the New England Journal of Medicine from colleagues of mine at NYU, Jose Scher, Andrew Neiman. And they looked at about roughly 80 patients with rheumatoid arthritis, psoriatic arthritis, or psoriasis. All of these patients were on some type of systemic immunomodulatory therapy, whether it be methotrexate or biologics, what have you. And they really didn't see a clear signal there for patients being on biologics having a worse outcome than patients who weren't on biologics. They seem to have the same natural history that you'd expect of anyone with COVID-19 illness. Now, the reality is these are small studies. You really would need, probably several hundred or maybe even a few thousand patients to really know the degree to which these therapies alter risk. There's also this sort of theoretical construct out there about COVID illness in general, which suggests that up front, immunosuppression may be a problem by making you more prone to getting infected and having progression of disease. But then in the back end, it actually may be helpful for people who have severe inflammatory reactions, ARDS, lung disease reactions to the viral illness. And that's why ruxolitinib, one of the JAK inhibitors, which most of us would feel like, a JAK inhibitor seems like the least safe of all the therapies, is actually being studied in clinical trials right now in patients who have sort of a cytokine storm presentation with COVID-19 illness. And so it's just a reminder of the yin and the yang of the immune system when it comes to dealing with infections.
Don't steal Dr. Friedman's thunder, Dr. Gelfand. He'll be talking extensively about the therapies. No, I appreciate that. It's interesting. So our patients have been out of our offices generally a lot in this last month and a half. What about your patients who come into the clinic for phototherapy versus many of the patients that have the opportunity potentially for home phototherapy? And of late, many of our colleagues have been talking about home phototherapy, and I believe that you have a study of which you are the principal investigator, the LIGHT study. Can you talk about that? Because I think it's very pertinent to this current pandemic.
Yeah, so the LIGHT study is federally funded by PCORI, the Patient-Centered Outcomes Research Institute. And it's a study of 1,050 patients. We're doing that at 30 sites across the country currently. As of today, we have about 230 patients enrolled. And so we were going on quite well with our enrollment. But we haven't enrolled a patient in the last 30 days. So essentially, office-based phototherapy really is shut down for most practices across the country during this time period. And now a lot of us are trying to get our phototherapy practices back up and open. Henry Lim and I have a paper that came out in JAD this week giving guidance to our colleagues about how to run phototherapy with social distancing. One of the pearls we recommend is turning off the fan in the machine so that way this reduces the risk of aerosols, for example, from patients being spread. Washing down high-touch surfaces, washing goggles with alcohol solutions, they're being shared between patients, spreading appointments out, things of that nature. We think if you're screening patients over the phone to make sure they're not acutely ill or having symptoms, the risk of spreading COVID is probably quite low if one follows these recommendations. Now, home phototherapy has been available for many years in the U.S. In fact, Medicare covers home phototherapy for psoriasis. Those devices are approved by the FDA and covered by Medicare. The reason why we're doing the LIGHT study is that there's not a lot of large U.S. data about these home devices. And that's created a lot of uncertainty amongst our colleagues who often don't want to prescribe them, as well as payers who often don't want to pay for them. And in our own experience, we've already been trying to work with our patients to get them home phototherapy, and it's been very challenging. A lot of our payers say absolutely no. For people who have widespread disease, they want them to use these small devices that won't be effective or potentially won't be safe for them. So it's really a hit or miss situation where it's an individual situation from patient to patient, what their payers are willing to cover for them. We are hoping to do additional work through PCORI. We have a grant under review for them where we're hoping to study really just using home phototherapy in a setting of telemedicine, where we wouldn't even see the patient in the office. We just see him online, prescribe the devices, and then see how insurance barriers play a role in impacting people's quality of life and delayed therapy and things of that nature.
Very fitting for our current times.